taking care of your bowel health.
So this webinar falls within a series of information sessions that the Alliance has been hosting for a number of years in partnership with the Scottish Government on women's health and in support of the Women's Health Plan. And I think many of you might have been to one of our previous sessions, but for anybody that is new, the aim really of these webinars is to raise awareness about key areas of women's health, but particularly areas of women's health that maybe we just don't speak about or we don't speak about often, and that there might be lots of questions around. And so we really try and raise awareness, but importantly, we try and challenge kind of myths and stigma that might surround some of these issues. So today we're going to be looking at women's bowel health, women's gut health, and that's really because I think understanding things around your gut, it's a really kind of popular topic at the moment, but there's still very much that kind of embarrassment around talking about things connected to that, especially if we're having issues with them. So, bowels, going to the toilet, incontinence, things like that. So what we're going to do today is just have a really kind of open and supportive conversation just to bring some real kind of clarity around, how do we look after our gut and our bowel health, but also maybe just give a bit of confidence to somebody that might have a bit of a concern, and kind of point them in the direction of what they can do to get some support. Also, some of you might be aware, but April is Bowel Cancer Awareness Month, so we thought it was just even more important that we all have a better understanding of what is normal when it comes to our bowel health. If I can introduce our speaker for today's webinar. So Dr. Vary Coley is a colorectal surgeon in the Academic Department of Colorectal Surgery at the Western General Hospital in Edinburgh. She specialises in colorectal and gynecological oncology, pelvic floor problems, prolapse and incontinence. Since 2001, she has regularly undertaken surgery in sub-Saharan Africa, treating women with obstetrics-related injuries and incontinence, for which she was awarded the OBE. And excitingly, she's recently published a novel about this work called The Bright Fabric of Life, and we'll send round a link to that so that you can have a nosy. So thank you so much, Vary. It's really lovely to have you with us today, and I'm just going to pass over to you now.
Okay, thank you very much for joining today. We're going to talk a bit about gut health, as Jen has said in her excellent introduction. I'm obviously coming at this a little bit from a surgical perspective because that's my job. But my experience of working in this area for about 20 years is that much of achieving good gut health is actually within easy reach of everyone. And often it's not so much about a complex operation, but rather about diet, trying to get making some lifestyle adjustments to get poo the way you want it, and things that are really in reach of everyone. So yeah, what we want to talk about today really is figuring out the best diet for you, the best poo for everyone, and how to kind of get your guts working the way you want with good control and future-proofed. Then we're going to talk about a few different issues on the bowel. I've got a little list of those. So these are the issues that I was going to touch on today. And this is not a comprehensive list of everything that can ever be wrong with your bowel, but these are very common issues that many of us have to grapple with, as you can see by some of the stats on the right. So we're going to talk a bit about irritable bowel syndrome, about constipation, piles and hemorrhoids, about diverticular disease, about incontinence, about bowel prolapse, and then a little bit about bowel cancer. Next slide. Now, as Jen said, these are topics that people often don't want to talk about, that they're embarrassed by, would rather pretend don't happen, but at the end of the day, it's all just plumbing. And hopefully we can manage to swallow any embarrassment and chat about it. I'm completely unembarrassed by bowels, I have to say. Next slide. So here's a picture of the bowel. I actually think it's quite beautiful. It is an amazing organ, basically, that takes our food from the stomach, and as it goes through the journey down those coils of small bowel that you can see in the middle, it extracts all the goodness that we need for our bodies. Next slide, please. Because basically, our bodies, as you probably know, are in a continual state of renewal and repair. And we're always having to make new cells and keep everything healthy. And the way we do that, the building blocks come from our diet, and it's all about the gut in terms of pulling out all these good things that we need and sending it around the body for the rest of the bowel, for the rest of the body to be healthy. And in the process of that, the bowel also manages to collect the waste and expel that. So the bowel is doing an amazing job. Next slide, please. And you can tell what an amazing job the bowel is doing just very generally by telling by looking at whether somebody looks healthy, are they active, are they able to get on with their life, not be undernourished, under height, the wrong weight, not in pain. So a good bowel is required to look as beautiful as this horse. Next slide. And that is all about what we put in. So we need lots of different things. We need lots of protein. And these are lots of foods that have protein. So milk, fish, eggs, nuts, vegetables, and pulses. Next slide. And we also need carbohydrates, which we find in these foods. Again, pasta, potatoes, rice, nuts, things like that. Next slide. And we need minerals and vitamins and fiber, which we find in fruit and veg. Next slide. So all in all, we need a balance. We need all of these things: protein, carbohydrates, minerals, vitamins, and fiber. Next slide. And we can cope with this sort of food. Our bowel manages to extract some goodness, but there are, as you'll see from this selection, there's not quite so much there as there was in the previous slide in terms of the healthy balance. Next slide. So this is just a shout out for the humble potato. I mean, I think it's quite amazing how much good stuff there is in a potato. You may have heard of the awful Irish potato famine in the 18th century, which was a dreadful thing when potato blight caused a failed harvest, and many people were very dependent on the potato. But it's not always so well known that in the centuries leading up to then in Europe and in the UK, there was so much famine because people were dependent on wheat, which was much more prone to bad weather and different diseases. And when potatoes came in, it really made a huge difference to the health of the population and our resistance to famine. Next slide. So you can be sure that these guys are eating a very well-balanced diet, allowing them to run and tackle and score tries, and they're looking good. Next slide. So some of the issues that we're going to look at to begin with, we're just going to look at IBS, constipation, piles and hemorrhoids, and diverticular disease, because they're all quite interlinked. Next slide, please. And they are generally to do with the bowel not working so smoothly. It's a long way from the stomach all the way down to the anus for poo to get through. It in average takes about 3 days for that journey to happen. And the muscle of the bowel wall is working hard there. It's pushing initially the food and then semi-digested contents and then poo all the way through a long way, maybe 20 feet or more. Next slide. And that motion of the muscle is called peristalsis, of the muscle pushing poo or food down. And in general, it's easier for the bowel, the colon in particular, to push against something, to have a fairly bulky, soft stool to push through. And basically fiber is important for that. So a high fiber diet from fruit and veg in particular can help peristalsis. Next slide. And then in the end, we get our poo. Now, I don't know if you're familiar with this. This is the Bristol stool chart, which is just a way of categorizing poo so that we can easily understand what sort of poo people are having. And you don't actually get a prize, unfortunately, for a poo. But if you were to get a prize, you would probably be looking for a type 3 or type 4 poo for most people. It is a bit variable. Next slide. So yeah, horses for courses. Everybody is a little bit different in terms of their needs, their diet, and the sort of poo that is the best one for them. Next slide, please. So to think a bit more about irritable bowel syndrome, a simplification of IBS is really that it's a discoordination of the peristalsis. So if you imagine two bits of the bowel, instead of it going through nice and smoothly from one bit to the next, you can have two areas that are essentially pushing against each other. And the pressure that can be generated is very high. If you see the picture on the right of two waves that happen to meet, as they meet, there's a huge buildup of water pressure there. And with IBS, that's what happens too. People get very bloated and crampy. Sometimes their bowel is moving much faster than they want, sometimes much slower. And the whole process seems to be quite discoordinated. Next slide. It's a bit like river rapids sometimes, instead of a nice, calm river with a smooth current. Next slide. And as I said, the high pressure of this can cause a lot of the pain and discomfort and difficulty that people have with IBS. Next slide. So in terms of trying to improve that, we can look initially at the kind of balance between fiber and carbs. So a diet that's very high in carbohydrate and also maybe red meat and low in fiber produces more of a hard pellety stool, and you need a much higher pressure to be able to get that through. So the bowel is working harder, having to squeeze harder. So sometimes increasing the fiber can reduce the symptoms of IBS. Next slide. And that's just a reminder of all our nice high fiber foods to try and keep everything smooth, low pressure as it's going through. Next slide. But then there are some foods that affect everybody in terms of changing that pressure. So caffeine is one of the big ones. Caffeine, of course, is a big stimulant. And it stimulates all of us, gets us all wound up, but it also stimulates your bowel quite a lot. It gets the bowel squeezing, which isn't always what you want if you're having a crampy pain. Next slide. And there's caffeine not just in coffee, but in lots of other things. There's lots of caffeine in tea, and there's lots of caffeine in energy drinks and even in hot chocolate. So caffeine is all around us, and it's not necessarily harmful, but it has an effect on the bowel that is important to know about. Next slide. Just a quick shout out for peppermint tea, which is the opposite really of caffeine. So it is a smooth muscle relaxant. So that means it relaxes the bowel wall so that it's less squeezy and sore, and that can alleviate some of the symptoms of IBS. Next slide. So these are caffeine and peppermint are things that affect everybody. Similarly, I think we all know that if you have a Vindaloo curry and 10 pints of beer or a couple of bottles of red wine, that's going to stimulate your gut. Maybe that night, maybe the next day, you're going to notice it. So all of us respond to these type of foods in a similar way. But there are some of us that have particular reactions to different things in the diet. Many people, for instance, are wheat intolerant. Now, a small percentage of those people will be celiac, but there'll be a lot of people who are not celiac, but who still have a reaction to wheat. Similarly, there are people who have the same sort of reaction to cow's milk. And then there's a smaller number who react to what's called FODMAP. On the right, it's a complex set of foods that have all these different features with the acronym FODMAP. Or histamine, which again has a mixture of fish, vegetables, alcohol, a whole load of things that can cause a histamine reaction. So it can be difficult to work out if you are one of those people that has a sensitivity. There's not always a reliable blood test or skin test that can tell you that. But what you can do is a diet of exclusion. So, for instance, with wheat or cow's milk, you would just take that out of your diet. So for 3 weeks. So maybe for wheat, that would mean no pasta, no flour, no biscuits, no cake, nothing with flour. And then you try and work out what effect that's had on your diet. Has it changed? Sorry, on your tummy, your bowel. Has it changed your bowel habit, your pain? It's usually good to take a diary. And then if there's no effect, then you're not wheat intolerant and you can go back to it. And you can do the same thing with cow's milk, with dairy, and with the various different foods that are mentioned in the FODMAP diet or a histamine diet. So that takes quite a long time, because each food that you're trying to work out if it's got a reaction for you, you'd have to exclude it for a number of weeks before you were absolutely sure that is out your system, no residual effects, and has it actually had any effect or not. So that's a big lot of homework. But some people, I think it's really worth doing that if you're suffering badly from IBS symptoms and you're not sure what the cause is. Next slide. Then some people find nothing that in their diet that is helping, and despite being on a high fiber diet, avoiding their caffeine, avoiding their Vindaloos, they're still very symptomatic, and they may need to turn to medication to help give them the type of gut throughput, if you like, that they want. And there are different types of medications out there. This is just a little summary of some of them. So one laxative, if you want to call it laxative, is not always like another, but these are the things that are useful for IBS. So softeners, things like lactulose and dulcalase, they can help to just ease the transport through the gut. Then bulkers, essentially fiber, and that can be an ispigula type fiber, or it can be a more insoluble fiber such as psyllium husk. And each of these will have a slightly different effect on people. Some like one, some like the other. But essentially, they're all trying to produce quite a formed but soft, bulky stool every day and keep the pressure in the gut low. Then the next lot are wash-throughs. Now, these are more literally washing everything through. So they are not ideal for people who are struggling with incontinence or diarrhea, but they might be more appropriate if constipation is more of an issue. And then lastly, for pain, bowel pain, just like the peppermint, you can get peppermint as a capsule, which is called Colpermin, and you can get stronger smooth muscle relaxants called Buscopan. So there are various different things for pain as well, and these can be obviously discussed with your own doctor. Next slide. So just to think a bit more about our high pressure system, there are other effects of that we're just going to talk about now. Next slide. And one of the most common ones really are hemorrhoids, typically from a type 1 stool there, so little lumpy stools, high pressure required to expel, which can cause hemorrhoids. Next slide. I haven't got any pictures of hemorrhoids, by the way, you'll be glad to know. One thing that does not give you hemorrhoids, despite what your granny might have told you, is sitting on a cold stone wall. I don't know why I was always told that as a child. It doesn't cause hemorrhoids, but there are things that do. Definitely constipation does, as I just said, and straining at stool. But then also sometimes very heavy lifting. And that can be through work, but it can also be at the gym. You know, people are very keen these days to do weights and squats. And I would say for all that's a good activity, it's important to protect your pelvic floor while you're doing it so that all the pressure is not being translated through your bottom, but rather that you would be squeezing up your bottom towards your tummy button while doing a weight or doing it sitting is another alternative. So being a bit careful about pressure. Pregnancy often causes hemorrhoids, the joys of pregnancy, but they nearly always disappear when there's not a baby pressing on the veins in the pelvis and causing back pressure on the veins at the anus, which is really why you get hemorrhoids in pregnancy. So we don't normally treat them, they normally just go away themselves. Might take 9 months, obviously. Next slide. So there are lots of things that you can do for hemorrhoids if they're causing symptoms. Occasionally they become very swollen and painful, and that I've seen that a few times in pregnancy. Again, we don't usually operate at that point. We would advocate bed rest, using an ice pack, which basically means a packet of frozen peas with a face cloth or a towel to let the thing go down, and painkillers. Then very important that to have stool softeners. You don't want a hard stool. You're trying to really have a soft stool and low pressure. There are various ointments that can help if the hemorrhoids are painful at the edge, things like Anusol or Germaloids that you can get from the pharmacy. And then occasionally people need a course of anti-inflammatory ointment that's on prescription, things called Sherry-Proct or Proctocidal. So many of these measures can be done by yourselves and just a few needing help from the pharmacy or the GP. Next slide. Surgery is possible for hemorrhoids, and you know, for most people, if they come to surgery, in the end they'll be okay. But it is a bit of a journey. It hurts. We always try to treat people conservatively as much as we can because it's almost impossible to have an effective hemorrhoid operation without a good 2 weeks of quite significant discomfort. Next slide. Prevention, always better than cure, isn't it? Especially if the cure is surgical. So back to that high fiber diet, soft stool, low pressure. Next slide. And of course, careful about the caffeine and the using the peppermint. Next slide. So just to talk a little bit more about constipation, I just wanted to run through some extra things on the medication. Next slide. There's lots of drugs out there, and it can be very difficult to tell what type they are. So I'm just going to run through that list once more. Next slide. We've already talked a bit about the softeners at the top and the wash-throughs, but just to complete the medications that are out there that you might see, there are a number of meds that are squeezers. So Senokot, Bizacodal, Dulcolax, they will make your bowel squeeze to help stool go through. So they can be very effective treatments for constipation, but they definitely increase the pressure in the bowel. That's how they work. And so they can cause a bit of extra cramping and pain. So most of us would advocate trying to treat constipation with softeners, wash-throughs and diet in the first instance because it's less sore, but with an awareness that squeezers can be used and might be required. Lastly, anal evacuators. We're going to talk a wee bit more about that later, but there is a whole set of medicines out there which can be popped into your bottom to help the last part evacuate. Sometimes when we say we've got constipation, what we're really meaning is that we can't get the stool out very effectively. It goes all the way around, but it won't come out. And so sometimes an anal evacuator is a better way of managing that. But as I said, I'm going to talk about that a little bit more in a minute. Next slide. So back to our prize-winning poo. For constipation, we're really trying to achieve probably a type 4 or even a 5. Next slide. So there's one more effect of the high pressure system that I just want to talk about a bit because it's quite a common issue in Scotland, which is diverticular disease. Next slide. So what that actually means, a diverticulosis means having diverticulae, and a diverticulum essentially means a pocket, which is what they've tried to show in the left-hand picture there. So like a little push through of the lining of the bowel pushing through the muscle fibers. And if you look on the right there, that's a view of it from inside the bowel, from taken at colonoscopy. And you can see all these wee holes on the left, and they are basically diverticulae. They're little pockets that have pushed through the circular muscle of the bowel. And what can happen? Well, first of all, they can bleed because often the pockets happen at places where the blood vessels come in and out of the bowel. It's kind of point of weakness, so they're quite likely to bleed. And then secondly, bits of poo, like these wee hard pellets or even nuts or big seeds, can get jammed in the pockets, in the diverticulae, and that can lead to infection. Which is what diverticulitis is. Next slide. Now that is usually treated successfully with antibiotics, sometimes antibiotics in hospital, but occasionally that bit of bowel needs to come out, and that's when a surgeon like me gets involved. I should have said it's normally the bit of bowel on the left, the sigmoid colon. It can be anywhere in the bowel, and in some countries there's a genetic predisposition to diverticular disease, and they tend to get it more on the right side of the colon, unusually. But in this country, it's usually the left. Next slide. So again, it's all about pressure and prevention. So we're really, really wanting a low pressure system to avoid diverticular disease, which is your fruit and veg, soft stool. Next slide. Definitely off the caffeine, and not forgetting about Coke and brew and things like that, and more things like peppermint. Next slide. In terms of the medication, you probably want to be avoiding the squeezers, which is why I've put them in red there. It's fine to have the softeners and the wash-throughs. You don't normally need the anal evacuators. But it's all about trying to find a regimen that works for you between diet and some of these laxatives that are very safe to take long-term. Next slide. So we're now going to talk a bit about incontinence and prolapse. Next slide, please. This is usually the most embarrassing thing that people really don't want to talk about. I think people are usually astonished when I tell them that, 1 in 10 people have issues with bowel incontinence. It's incredibly common, and it is just about the plumbing, and there's lots of things that we can do to help. Next slide. There is a big impact, though, a big vicious cycle of impact from incontinence, and people find it impossible to manage. They don't want to talk about it. They don't want to tell their partner. They don't want to tell their work. It can stop them going out because sometimes physical activity brings it on. It really is a very difficult thing to manage. I don't want to underplay that, but there are lots of things that we can do to help. Next slide. When we're talking about incontinence, we're not just talking about leakage that people have no awareness of. We're also talking about urgency. And I think sometimes that's more common even as an issue. And anybody who's been to any event, football match, rugby match, anything like that, will know that there's always an enormous queue for the ladies' toilets. And sometimes you just can't get there in time. Very, very, very stressful. Next slide. So in terms of our poo that we want for incontinence, in actual fact, we want something much firmer. We don't want really our type 4 even. We're looking much more for type 2, maybe type 3. Don't really want the little pellets, type 1, because they can escape. So you're still wanting quite a formed, bulky poo, probably type 2 or 3. And then we're just going to talk in a minute about how we're going to achieve that through diet and also exercises and medication to manage incontinence. Next slide. In terms of that poo, we might have to change the balance with a bit less on the fibre, less pulses and fruit and veg maybe, and a wee bit more of the carbs. Next slide. So dietary. As I've said, a bit more carbs, maybe a bit more insoluble fibre. All these things on the right run through the bowel quite quickly. Curry, beer, wine, caffeine, and lentils. Lentil soup's a big one. So you might want to be having a bit less of that as you're trying to produce a firmer poo, which is easier to hold on to for longer. Next slide. Again, there may be particular things in the diet that cause intestinal hurry and incontinence, and there's all that homework to be done to look for that, to find out if there's one thing in particular that you just can't digest that runs through you. One other thing just to mention in diets is that some people, particularly if they've had their gallbladder out, can't digest fat so well. So if they have a very fatty meal like cheese on toast or lots of dairy, very creamy sauces, that will cause diarrhea and sometimes incontinence. So there can be specific things for individuals. Next slide. Just moving on to pelvic floor exercises. Everybody's got a pelvic floor. It's not just women after childbirth. And exercises to improve the strength of that pelvic floor are appropriate for everybody. Everybody's got muscles, and if you work a muscle, it gets stronger. When you're in the menopause, for women, that's even more a time when you really want to be working those muscles, because as you lose your estrogen, the ligaments of your pelvis become a little bit softer, there's less support, and the muscles become much more important. You need to really work those muscles. The NHS has a squeezy app, which is really a reminder to help tell you that you need to squeeze, because it's very easy to forget. Next slide. In terms of doing the exercises, you don't need to be turning yourselves in knots, don't need to be all lycra clad and at the gym. It's a much more simplistic thing of just pulling up from the anus towards the tummy button, towards the umbilicus, and trying to hold, as if you're trying to not let any wind out, ideally holding for 10 seconds. Now, some people can't really feel if they're squeezing or not, and they may need to have some help from a physio or a bowel nurse to help know if they're squeezing. There are various reasons for that. Some of them are related to childbirth, when quite delicate little nerves down there can be fractured and just lose their function, so that people lose their awareness of whether they're actually squeezing or not. So there is help available. But as I said, it's not too complicated. It's just a squeeze up. Probably easiest done when lying in bed or sitting in the couch. Next slide, please. Okay, so we're now going to look at medication. So there's 3 different types, really. Bulkers, aids to evacuation, and then loperamide. And we're going to talk about each one. Next slide, please. And essentially, what we're trying to achieve is quite a bulky stool, because it's easier to hold that. It's completely evacuated with nothing left, and then no more for the rest of the day. So that's what we're trying to get to. Next slide, please. In order to do that, the first thing is trying to get the bulky stool. And we've talked a wee bit about the diet, but husk can be a big help for this. That can be ispagula husk or psyllium. My experience is that psyllium husk works a bit better. It's an insoluble fibre, and it tends to be more effective at producing that bulky stool. Everybody's different. Some people don't react well to it, so it's worth trying to find the one that works for you. But that's what you're trying to do to get your stool bulky. That's the first thing. Then the second thing is our aids to evacuation. So I mentioned that a little bit before. Some people, what they find is they manage to go to the loo, but then they haven't quite finished. So 10 minutes later or half an hour later, something else comes, often with poor control. And so a strategy to combat that is that after going to the loo, you'd pop something in your bottom. So you go to the loo, clean up, and then pop in a little suppository, run it under the tap burst, or a scoosh of foam. It's got a nozzle and an end, and you scoosh the end and up goes some foam. And then I suggest to people that they sit back on the lid of the toilet, squeeze their buttocks together even with their hands, so that you're holding it in for a few minutes, then lift up the toilet and go again. So that you stay in the bathroom, but you're trying to make sure that at the end of leaving the bathroom, everything is out. Obviously, it takes a wee while to get used to all that. Many people don't need it if they've managed to have a complete evacuation by having the stool all bound together with the husk. But if they haven't, this is something to try. And then the next thing, once you're sure that it's all away, if you want to make sure there's no more because you're walking the dog or going to a wedding or whatever, is to use loperamide or Imodium. It's the most effective drug we have at stopping the bowel from squeezing it, unstimulating it. And it's perfectly safe to be taking it. The only caution would be to make sure you're not using it to mask new symptoms of bowel cancer. And we'll talk about that a wee bit later. But once you're sure that there's nothing else going on, and this is just the way you are, and we're trying to alter it, then Imodium can be used long term. Next slide. So just to talk about one more thing about the aids to evacuation, some people really cannot empty. And you may have heard of a thing called colonic irrigation, which used to be quite popular about 20 years ago. Still, some people do it. You can do a mini irrigation that bowel nurses can teach you just to empty out the last part of the bowel. The little thing I've shown on the left there is about the size of an avocado, and you can just squeeze it so a bit more water goes up and washes it out. And then on the right, some people need to have a much more involved irrigation, really trying to empty the last foot or so of bowel with up to 1 litre of fluid. And so these things all exist. Many people use them. Many people don't ever want to really discuss them, but they are all there, and there's help available if you think you might be needing that sort of aid. Next slide. In terms of surgery, a very small percentage of surgery of patients that I see end up needing surgery for their incontinence. Most commonly, probably, it's to repair something that's been damaged. Next slide. That can be an injury that's happened at childbirth. So as the baby comes out, it can cause a break or a tear in the muscle. And if the muscle is apart, it doesn't work so well. So sometimes it needs to be brought back together again. Next slide. And sometimes it's about prolapse. So just as for women, the uterus or the bladder can come down, the vagina can come down with prolapse, but the bowel can actually come down as well. It's probably the same cause in terms of softening of the ligaments, maybe some trauma or damage done at childbirth, different things. There are some people who are more prone to prolapse. People with hypermobility have a little bit of an extra risk of it. Also, people who are very overweight. And basically, it's like a sleeve just coming down too much, but it brings with it mucus, sometimes a bit of blood, a bit of poo. Difficult to manage. Next slide. That's something that can be fixed, though, with surgery. And that can be a kind of hoik up through the abdomen, or it can be sometimes a repair done at the anus. And there's different operations that your surgeon would talk to you about if you were having prolapse. It's not at all a dangerous thing. Not everybody with prolapse wants or gets it fixed, but it can be fixed. Next slide. This is a little bit of more of a weird thing. So this is an uncommon thing. I just want you to know that it exists. So some people have lost the nerves to their bottom and they really have no warning ever that they're going to have a poo. And we can sometimes give them that feeling back by putting a wire like a pacemaker through their lower back onto the nerves that are supposed to be telling them that they need to go for a poo. So that's a very unusual thing that we do, but it's nice to just know. Next slide, please. And last, stoma. I have many patients who come to my clinic saying, oh, my bowels are terrible. I think I need a bag. And they're terrified of that. I have to say that the percentage of people that I see with incontinence who end up needing a stoma bag is less than 1%. It's very rare. There are a few people who will have a better quality of life with a stoma than without, but it's pretty rare. So don't let the fear of that stop you coming for help. Next slide. So in summary, bowel incontinence is incredibly common. You can nearly always manage it with a combination of diet, exercise, and medication. Very few patients need surgery. Next slide, please. So we're just going to move on for the last 5-10 minutes and talk a little bit about bowel cancer. The lifetime risk for women in the UK is probably around 5%. Next slide. And we're going to just talk a little bit about bowel screening, about symptoms of bowel cancer and how you can prevent it. So next slide, please. So in terms of our risk, you'll notice from these slides that although it's a bit more common in men, it's still quite common in women. I think sometimes people feel that bowel cancer is a disease of men, but it absolutely isn't. The other thing to notice from those stats is that our rates in Scotland are a little bit higher than in the other countries in the UK. And there are reasons for that around perhaps genetics, but also the risks of bowel cancer and how we prevent it, and perhaps also our uptake of screening. Next slide, please. So our uptake for screening is a little bit less than England, and a little bit less than, a tiny bit less than Wales. Next slide, please. So the purpose of the bowel screening is really to look for polyps. And the journey from a normal bowel to a cancer of the bowel takes a long time, more than 5 years on average. And on the way, during that journey, initially there's usually a stage where there are benign polyps. Not all polyps turn into cancer, but all cancers start as polyps. So they all start as much smaller wee lumps in the bowel, which are removable. Next slide, please. So what the bowel screening is really about is looking for evidence of polyps, because usually a polyp produces a little bit of blood and you can detect that in the bowel screening. There's no symptom often for a polyp. People would not know they had one. They're very small, they don't cause a blockage. The amount of blood is so small that you can't see it usually, but you can detect it on the bowel screening. Next slide. And then if your bowel screening is positive, usually you would have a colonoscopy, a camera test, which goes under sedation usually. A camera is inserted around the bowel to look for these wee polyps. And the beauty of that is that if they find a polyp, they can nearly always remove it at the time. So the colonoscopy is diagnostic, but it's also therapeutic. And if you remove those polyps when they're tiny and benign, they never have a chance to turn into a cancer. Next slide. So that's about bowel screening. That's for people who really don't have any symptoms, but we're trying to work out if they've got polyps. And I think in Scotland, it's between age 50 and 74, because most people, not everybody, unfortunately, but most people, if they're going to have bowel cancer, the average age is about 60. So we start 10 years before that to look for polyps. There are symptoms, though, of colon cancer. They include these ones: blood in the bowel, a change in the bowels, usually to persistent diarrhea. That's what we would mostly be worried about. Abdominal pain, weight loss, and anemia. All these things should be investigated through your own doctor. And usually they would actually send off bowel screening type tests in the first instance, and see what they show. Not everybody automatically goes for a colonoscopy. Next slide, please. In terms of preventing it, you can do things to prevent bowel cancer. You can, with lifestyle adjustments, you can halve your risk of bowel cancer. And the things that we know make a difference would be exercise, 30 minutes of brisk exercise per day, fruit and vegetables, 5 a day, probably associated with a slight reduction in red meat. Taking a small dose of aspirin probably does reduce your risk of bowel cancer, but we don't advocate that generally because aspirin has lots of other side effects. So although we know it can prevent bowel cancer, it's not advocated for the population because of the side effects of aspirin. Statins, maybe, also vitamin D, maybe, but again, not enough evidence for the population to be advised to be taking them. Next slide. What is important, though, is avoiding obesity, cutting down alcohol, so not excess alcohol, and completely avoiding smoking. All of these things contribute to your risk of bowel cancer, so they are things that you can alter. Next slide, please. So I think this is the summary of everything we've been talking about. Basically, to encourage you to like your bowel. It's your friend. It helps you be healthy, and you should treat it nicely. Many conditions that cause problems with the bowel can be treated with dietary adjustments, with extra fluid, and with gentle medications. I'd encourage you always to try and manage your incontinence if you have that problem. Just like IBS, it can be managed. There are some things that need surgery and some causes of incontinence that can be treated surgically. And absolutely do the bowel screening. It's such an opportunity to avoid bowel cancer. Next slide, please. So I apologize for this. This is one horrible picture. We all hate warts, don't we? Just a shout out for the HPV vaccine. It's so vital that people have it. Teenagers, it will stop them getting genital warts, including anal warts, and it will cause a reduction in cervical cancer of 70%. It's massively effective. Bowel-wise, anal warts can get rid of them. So have the HPV vaccine. Next slide, please. And just lastly to say, we all poo. Bowels are part of life. Better that we talk about it a bit and embrace it than feel embarrassed and let them dictate to us. Last slide. It's always better to have that nice, smooth current of a river rather than high pressure rapids. And I'm going to finish on that slide. Thank you very much.
Thank you so much, Fari. That was honestly fascinating. I learned so much, and I can see, don't know if you can see on your screen, there's lots of love hearts and claps coming up. So I can see from the chat and everything that people really appreciated that. Just having a very no fuss, open conversation that just kind of debunks a lot of the kind of myths and just puts into the open topics that we just don't talk about. So thank you so much. There is quite a few questions that have came in, and I've kind of grouped a few questions together because a few people are asking the same thing. We've got about 15 so minutes for questions, so we should be able to fit in quite a few. So I encourage, if anybody's got a question after seeing the presentation, feel free to add them to the Q&A and we'll pick up what we can. But just to get started, so obviously there's different things that can happen with the bowel, and therefore different treatments and things like that. But I'm wondering if you could speak a little bit about the process that someone might go through if they have a concern and they're looking for support. So they would go to their GP, I imagine, to kind of first raise a concern. What might they expect? Is there kind of tests or examinations that might be carried out? And also, what information would it be helpful for people to kind of bring with them that's helpful for their GP or their consultant to know?
Yeah, so I think that's a really good point. People would definitely should expect that they would be examined. So one thing I didn't say is that the bowel screening is not great at picking up something right at your anus. So unfortunately, it is important to have an examination, including a quick internal there, because things can be missed just at the anus. From the bowel screening, it's really trying to pick things up a little bit further in. So it's important just to have that warning that it's quite likely that people would, have an examination. Now, that can be done by ideally just one person, and it can be a female, and you should ask for a chaperone. And if it's a problem for you, absolutely voice that. But I think it's important to just have that warning. In terms of information that the doctors might need, it's very important to know if you're on a blood thinner. So knowing that they should know that anyway, the medication. Family history is important. It's not vital. Having a primary relative, which means like this is in terms of bowel cancer, having a primary relative with bowel cancer, like a mother or father or sibling, it increases your lifetime risk from maybe 5% to about 12%, depending on their age. But it definitely doesn't get you up to like 100% or anything like that. And there are one or two conditions that do lead to bowel cancer, and the doctor would know about that. But it would be unusual. These are only like 1% of the population that we see that actually have bowel cancer have a sort of genetic condition that leads them to that. And in terms of incontinence, I think a lot of the things that I've suggested are available for people to try on their own. And in general, I would encourage you to do that. I mean, the doctor should help you and support you, but there's many things that you can do yourself. And many of those treatments and medications that I've suggested, they are for long-term use. They're not like a course of antibiotics. They're something that you would sort of stay on. I don't know if that answers your question enough, Jen.
That's really helpful. Thank you so much for that. So quite a few people have asked around this particular next question, so I'll kind of generalize it a little bit. But if you are taking medication or you've underwent treatment for something, or if you have a particular illness or a chronic condition and you're managing that, some of these medications might impact on the gut, or even maybe damage the gut a little bit. People have mentioned things like radiation therapy, even antibiotics to some degree, just kind of upsetting maybe some of the bacteria. So can you speak a little bit about that, and also how might people kind of manage that if they are taking medication?
Yeah. So antibiotics first, obviously that's a common thing. People take a course of antibiotics, and it can certainly have an effect on the bacteria of your gut. You're right. You can often reset that with Actimel or live yogurt, or probiotics, which again are available in the supermarket or the chemist. Occasionally people have very long-term antibiotics and have a real problem with the gut, and more involved treatment is required for that. But again, that's pretty rare. I think nearly everybody we can kind of just let our gut recover a bit with time, and a bit sometimes with these measures, probiotics and natural yogurt. There are a few other medications that will affect your gut as you're taking them. So medications for diabetes, statins, things like that, they have effects on the gut, definitely. And obviously painkillers cause constipation. So it's perfectly okay to take something to balance that. So for instance, if you're needing a lot of painkillers, you're bound to get a bit constipated, and I would definitely be taking laxatives, ideally softeners and wash-throughs, which are gentler on your gut to combat that. And similarly with statins and things like that, they often, you're looking more for bulkers probably, and things to slow down the gut, similarly with the diabetic medication. In terms of damage, yes, radiotherapy unfortunately is a complicated thing, and that really can be problematic, and it would depend which bit of the gut was affected and how it was affected. Very rarely people can have a narrowing of the gut, so then you have to be very careful about what you're eating, that you're not eating things that are insoluble like nuts, skins on potatoes, big chunky bits of raw vegetables that won't get through a narrowed gut. So you'd need to know exactly what the damage was and adapt your diet and your medication accordingly. What else? Non-steroidal painkillers, they can damage the gut as well, particularly Brufen and Voltron. In long term, they can make diverticular disease a bit worse. They can cause bleeding from ulcers. So they are medications to be wary of long term for the gut. And the last thing is the bile salt malabsorption. So I think that's quite an underdiagnosed issue. There are some blood tests for it, but my experience is that sometimes the blood tests are negative, but you can tell that people are definitely struggling to absorb fat, which is what your bile is for. And so that they are better on a low-fat diet, and sometimes even on a particular type of medication that helps you digest fat. So again, that's something to just be aware of. People who've had their gallbladder out or who've had some bowel removed, they quite commonly have bile salt malabsorption, but not just those people.
Perfect. Thank you for that. So you mentioned there when you were speaking about particularly to do with kind of microbiome, probiotics, and there's a few questions around this. So I wonder if you could speak a little bit more about it, because I think there's a lot of things that are labeled gut friendly, and I think talking about kind of gut friendly foods is very popular on like social media and things like that. So if you could bring some clarity to that a little bit, that would be really helpful. You know, what are we talking about when we're talking about probiotics? I've also heard about prebiotics. You know, what's the difference? What do they do? If you could just speak a little bit about that, that'd be really helpful.
Yeah, there's a bit of snake oil about some of this, and there are, just as a warning, there are people that are making a lot of money out of our concerns about our bowel, and I'm not anti probiotics or prebiotics in any way, but I think sometimes we can overcomplicate what our gut actually needs, and really looking at the more basic dietary requirements that we've got in terms of our protein, our fiber, our fruit and veg, our carbohydrates, you can probably manage without them in most cases by just trying to have that healthy diet. In terms of trying to change the microbiome, I think probiotics are very good for that. So if you've had a very bad diarrheal illness or traveling abroad and it's all got upset, or antibiotics, then I think there's definitely a role for them there. There's lots of research done in whether they can help with various different disease states, such as inflammatory bowel disease, pouchitis. There's different things that you can have that there's some evidence that probiotics and even prebiotics, which are still affecting the microbiome, but just in a slightly different way. But I don't think there's much evidence that a normal, healthy person without any symptoms needs to have prebiotics or probiotics to be healthy. I think that there's a lot of people trying to promote that because that's a massive market, but I'm not sure that there's much scientific evidence behind that would say, yes, this is what you need, and this will make you have a perfect bowel and live forever. I think we can simplify things and go back to diet for a lot of that. I mean, obviously, you know, as a surgeon, this is not really my absolute bread and butter expertise. And I would, if you really wanted more information about it, I would suggest talking to a dietitian or a gastroenterologist.
Yeah, no, that's really, really helpful. And we can send round, there's information on NHS Inform a little bit as well around kind of, diet and support there. So we can send around a link to everybody in a follow-up email as well. But yeah, I think that's a really good point around just being mindful of the kind of consumption culture around health. And like you say, natural yogurt, that's good for you anyway. You're probably going to be eating it just as usual with your granola or whatever in the morning, and that's gonna give you the probiotics that you need without maybe having to be, taking supplements and things like that. I have a question here that I have just lost. Sorry, 2 seconds. That's the problem. You have multiple pieces of paper here. Yes. So somebody has asked around how can you support somebody else who is having problems with their bowel that might have bowel incontinency? And I think particularly when you think about people that might be caring for a loved one, how might be experiencing incontinency, how can people support somebody and help them to manage it?
Yeah, I think that's the right word, actually, manage. So sometimes what you're trying to do is help them have a managed evacuation. So one of the things that can be difficult, especially as people become older or they're more infirm or they have cognitive decline, there's many reasons. They can forget that they need to go to the loo until it's too late, or sometimes they don't even get the warning. So when we talk about having a managed evacuation, we sometimes mean, right, well, we're just going to actually go at a time of day and try and make it happen. And even using those anal evacuators I suggested, like the suppositories or mini enemas, physically to make it happen and to help be in the loo and actually have a motion at a time that is convenient, rather than sitting in the chair wondering at what point it's going to come. And that is easier also if the motion is quite firm, so it's not diarrhea. So again, diet, medication, trying to have that one poo a day and not being afraid to use Imodium. Older people are far more susceptible to drugs, if you know what I mean. So Imodium can sometimes be too strong. You can half the tablets, but you're trying to actually manage it, make it happen. And I guess just to be aware that not everybody gets the warning they want to go, and not everybody even can remember if they've been or where the loo is. And obviously to try and sensitively talk about it, and to be careful about what you're feeding people, so that you're not giving them medication, a cup of coffee every hour, and then they're going to have a lot more visits to the loo, both for the bladder and the bowel. Yeah. Or a cup of tea every hour. I mean, in the hospital, you get offered a cup of tea every hour. So, I mean, it's just, I can't change it. But it's not really it's not ideal for your bowel.
Perfect. No, I think that will give people quite a little bit of support to take forward. I'm just conscious of time, so I've kind of got one final question, and then we'll wrap up. There's a few questions around this kind of, and I suppose it ties into the things you were saying around, we don't speak about bowel issues, especially as women, and so concerns that we have are often, we just put up with them. So how do we change this culture around the idea that incontinency or bowel issues are a kind of par for the course of aging or of post-pregnancy? How do we change this culture, and how do we start speaking more openly about our bowel health?
Yeah, I think it's all about just airing it. And I think what you've done here with doing a webinar about it is a big step forward. And I know that we're going to look at NHS Inform as well, and those sorts of things can these ventures can allow a bit more of a space to talk about it. See, they're very important in saying, yeah, it's okay to talk about it. You don't have to be ashamed of it. I'm sure part of it goes back to when we were children and we were being potty trained, and we would be told we were naughty, you know, if we had a if we missed the potty and had a poo. And I think a lot of that is engendered deep within us. It's difficult to change that. But you know, women, we talk about almost everything apart from poo. So the more people who talk about it, the better. I mean, I think uh, there's lots of topics that people never used to talk about. Like there was a thing in history called the Little Book, I think it was called, or the Women's Book, and it was basically disguised as a housekeeping book, and it was how to manage natural forms of contraception, you know, not how to get pregnant all the time, and how to look after yourself. And that was sort of widely distributed, but under the counter kind of thing for years. And now, of course, people are amazed. You know, of course, we all talk about contraception and family planning, but it was absolutely taboo, only maybe 150 years ago. So I think it will get better. But the more that we all are willing to talk about our bowels, the better. It doesn't make us unclean in any way. It's just part of life, and should not feel there's any stigma to it.
Absolutely, yeah. And the more that we talk about it, the more we are aware of our own bodies and our own normal, and therefore when things might be not normal and we should maybe get them checked out. So, yeah. Well, thank you so, so much, Vary. I think that was so interesting. There's so many comments in the chat from people that have just really, really appreciated today. If I can also say thank you to Jackie and Linda for interpreting for us today. And also you'll have seen, I forgot to mention her at the start, but you'll have seen Claire Mills on our screen, who is our graphic illustrator, who's been kind of creating a complementary graphic for this webinar, which we'll share with everybody as well once it's ready. And thank you as well to our Scottish Government Women's Health Plan team, who are our partners for this webinar. We've mentioned a few times NHS Inform. There's lots of information on there around bowel health, but also around some things that we've kind of touched on as well in the course of this webinar. So things around pelvic health, pelvic floor exercises even, things around diet and nutrition and exercise. So I'd encourage you all to have a look on NHS Inform. There is actually a women's health hub, particularly on NHS Inform. We have a mailing list at the Alliance. You can sign up to that and you can get a monthly e-newsletter, so you'll be able to find out about other sessions that we have planned, or kind of new resources or kind of news around women's health. So I'd encourage you all to sign up, and I'll put this all in an email that I'll send to you after this webinar. And then finally, you can watch our previous webinar recordings over on YouTube. So that's various topics from menopause to women's heart health. So I would encourage you to go away and have a look and share with anybody that's interested. But thank you again, everybody, for coming along today. Thank you to Barry, and hope to see you again soon at our next session. See you later.
For more information, see the links in the description box below.